So I'm going to ask actually to please let members of the round table ask questions first. So if you're a community member, just don't go away, just maybe step aside. And Ernestine, why don't you lead us off?
Okay, Ernestine Willis, pediatrician at the Medical College of Wisconsin. And I thank the panel for their discussion of the evaluation, because the nonprofit sector and community members really value that. But here's an area what I wanted to just get your reaction to, because you talked about strategy and tactics that you use, and you gave some how-tos that were practical how-tos to help researchers find their way to truly do community engagement. But as Andrew started out talking about the ethical components of research, I noticed, and knowing I do CBPR research also, so I'm very much aware of the principles of CBPR, and one of the key principles of CBPR is power sharing, equitable power sharing. And I didn't hear anyone talk about that. And the reason I'm asking you to react to it, because we have to acknowledge our historical context of researchers coming into the community. So would you talk about the principles of CBPR talks about equitable, and then they go on to talk about power sharing. And I'd like to hear tactics and strategies that you propose that me and other researchers really consider when it comes to demonstrating to the community that you engage that power sharing. And I'll give you one example. I try to always have memorandums of understanding and make it balanced, but I want to hear what you propose as options for the audience who are here.
All right, thank you so much for that question. And I'll start by saying that one of the most important aspects of CBPR and equitability and power sharing is transparency. And I'll share this quick little story now. I hope Dr. Rima Rugg gets a little laugh. But I worked with, at Harvard, one of my mentors was Howard Koh. And we were putting together the budget. I was working in a community in Jamaica Plains, Dimmick Community Center, and they said, you know, we're not going to do this. We want to see all the salaries that everybody is making. And I said to myself, they don't really want to see my salary, because the first year postdoc salary, you know, it's really, really low. But anyway, so there was that tension. So I go to Dr. Koh and I tell him, you know, what the issue is. And he looked at me and he says, what should we do, Sherry? And I said, I think that we're going to have to share them, because I said, if you're really partners, and I say, I'm just going to use Jennifer, who's one of the roundtable members. If I say, Jennifer, do you want to go into business with me? And you say, sure, Sherry. But I say, Jennifer, going into business, I can't show you the contracts. I can't show you the grants. I can't show you the financials. Would you want to do business with me? No, it's the same thing with the community. And so one of the things we did, which Dr. Koh suggested, that we do a memorandum of understanding. But then when we submitted grants, we made sure that the communities got money, and the reviewers loved that. So it wasn't like Harvard was keeping all the money. The communities, the health center, they got substantial amounts of money. And recently at Georgetown, we put in a big U54, and that was one of the things I said to them. I said, NIH and a lot of the national funders are looking to see how vested we are in being equitable, and part of equitability, demonstrating that, is that these communities get money, also that they are co-authors on the manuscripts, okay, not just the academicians, but they're co-authors. So those are some of the things that we do. And also our community advisory board, it's not an academician or a director. It's usually people who live in the community that chair that community advisory board. And I think those are ways you can demonstrate equitability, and using, as someone said this morning, the consensus model. And so the greatest compliment to me is one of the community members was trying to call me at Georgetown, and they called the main number and they said, you know, can we speak to Sherry Wallington? And so the receptionist said, said, "Oh, you mean Dr. Wallington?" And they say, no, she's just Sherry to us. And that was such a compliment because they didn't see me as this big Dr. Sherry, but they just saw me as one of them. And I say, when you can get to that point, I think that you're on the road to making sure that you can do this type of research in an equitable way.
It reminds me of one of my mentors in the practice facilitation field, Lindy Knox, said to me, and she said, when they give you the key to the back door, that's when you know you're in. Yeah, great. Wilma.
Wilma Alvarado Little, member of the Roundtable. So I really appreciated your comment about the inclusion of the community in publications, because that was going to be one of my questions as well. So thank you very much for that. And as I'm listening, I really appreciate all of the comments that have been made, because sometimes folks just don't get it. You know, they just don't. And when I mean folks, it's like maybe outside. And even, you know, health literacy, English to English, is sometimes very complex to understand by others, perhaps, you know, in other areas. And then the whole research piece can be difficult for others to understand how you get from point A to point B successfully, whatever that definition of success is. And so then we add the cultural and linguistic layer to all of this. And so one of my thoughts was about using the community advisory board model and taking into considerations that sometimes our communities don't fall into that model. So we might unintentionally be sending a message, this is my need for you, not that this is your need. And so one of the questions I have is, in communities who do not traditionally fall under this, for example, in upstate New York, I'm working with an indigenous community from Oaxaca, Mexico, that does not fall under the CAB. Okay, and so
CAB stands
Community
for?
Action, or a Community Advisory Board, right? They don't fall under this model. And so we've had to be very careful on how to be respectful, because basically what we're doing, and it could be misinterpreted as, I'm inviting myself to your house, I'm gonna look around your house, and then I'm gonna leave. Right? So having to be thoughtful, if you will. And the other piece is for those communities whose primary language is not English, and what is the role of communication there, and how is all that incorporated into a quote-unquote successful project. So I'd just like to hear your thoughts about communities who have a different hierarchy or sharing of power, if you will, in the process when we're doing these types of evaluations, and the possibilities of including them from the very beginning. As you said, you know, you don't reach out to the community, I've got 30 days before this grant is due.
Okay, okay, good.
No, go ahead.
You sure? Okay, you know, that was a lot of good thoughts and a lot of good nuggets in there. And I would say the Community Advisory Board, that's just one way. And we actually did not come up with that. When I got to Georgetown, one of the things we did was to have town hall meetings. So it might be a community advisory board model. It could just be town hall meetings, because what we heard from the community was, you know, you're doing all this, and Georgetown, like many institutions, was just saying, oh, that's the place only the white rich people can go. You know, I got my PhD from Howard, so I came from a different perspective, and so I understood that. So how do you change that image of Georgetown being only for the rich white people, say from Potomac, this really high income area? And so one of the things we did, we just started meeting with communities. And that's when they said, you know, we would like to be at the table. And so for us, one way to have them at the table was to have this community advisory board coupled with, you know, we do town hall meetings 3 times a year so that we could understand. We felt like we knew what the priorities were, because like I said, we look at the Healthy People 2020. We looked at the cancer registry data, which was clearly telling us breast, cervical, and prostate cancer were the high priority cancers in DC. But then they told us some other things around environmental concerns and things like that. So what you have to let the community tell you what model will evolve, what that they will fit into. And I think doing town hall meetings, we have peer-to-peer training that we do where we have community liaisons go in some of these public housing communities and they give us feedback on what they feel will work for them. So I think that's one way. And okay. Mm-hmm. Yes.
Another strategy that has worked is FQHCs are a great resource, especially the community health workers that help support the work, and they're very knowledgeable of the community. You can go in there and talk to them, provide a stipend for their time, which I think is very important. And they can give you, the state of that particular community. You can then ask them to help you recruit members. One of my favorite things to do is action research to really get at the difficult to reach. Those who are transient, those who, are recent immigrants that don't speak any English. How do you get to them? Those outreach strategies are very important, and that's one strategy to get to them. And I also wanted to loop back on the being purposeful. If what you're trying to achieve within your intervention is really get at the lowest of the low literate individuals, you do have to engage in these kind of strategies. And the last point is the power question, which is a very important one. And sorry if I think it was implied in some of my earlier comments, but it is very important. Thanks for lifting that up. It's really tough as a researcher to let go. You have your design, you have your instruments, you know what works. It's really difficult to then present it to someone, this is what we have in mind, what do you think? And going from a 10-page instrument to a 1-page instrument is just, it is painful, exactly. So I think that letting go while still managing the process and staying true to your research methods is where you open up that can of worms, which is sharing power. So I think that's the critical point for that. So I just wanted to loop back to your original question.
We're going to take Michael, and then community members, please come to the mic.
Michael Paschola, Boston University. I wanted to give you guys a crack at something that came up earlier. A very commonly used term during this panel is this word community. And, there are formal communities, there are informal communities. There's a lot of, how are you using this term? Because it's, if someone recruits me to represent a community, maybe I can do it, maybe I can't do it. In what sense can I do it? And yet we are constantly engaging with people as if they represent this or that or another thing, and is it legit? And so what does this word community mean for you guys?
Because it's such an easy question.
Yeah, so I think if I had to keep it very, very short, I think community is everything, right? Or can be anything. If you think about people with a particular condition, like a community, geopolitically community, there's so many different things. I think that is the power of the community guide for us is we can sort of look at all of these things, or we feel the responsibility to look at all of these things. Because a community for one person, say living in a city, but they're culturally, they are trying to fit into the city. There's so many things that way, but you can't, so I think community is basically just like public health. Public health claims everything, so it's the same way.
Anybody with operationalizing definitions?
Well,
Yeah.
I think I said it earlier that when it comes to interventions, implementing interventions, and you identify a community to serve, it's usually zip code, it's jurisdiction, it's location. But once you start trying to find out more about it, what is common is that it's about relationships. It's people that have something in common with somebody else, not just a zip code, but a philosophy, a way of doing things, a hobby. And to your point, it can be anything really. And operationalizing community within the context of an intervention is step one. What is what community are we serving? For the work a lot of the work that I do, it's the service population for a community health center. And even then, we get the community health workers to tell us who should we invite, who should we talk to, and it's people outside of the zip code. Because they get a specific service from that health center. So it's, I guess I'm just adding to what you said, that it can be anything, and it's up to us as researchers to help operationalize it early on in the research.
And I would just add to what Oscar said, it's about relationship, but 3 important words that go with that relationship are sharing, equitability, and respect.
And I was invited to moderate this panel, I believe, because of my expertise in research and evaluation, not in communities, but that, of course, is not going to stop me from positing. And because I come from a cultural competence field as well as health literacy, I tend to think about communities in terms of ethnic communities, and then thinking about who are the community leaders. And I don't know how you negotiate this in terms of there's very often a lot of tension about who are the legitimate leaders and how you navigate that. So I don't know if that piece of it of trying to figure out, and Katina said, well, we had to know one person in the community and then we would snowball from there. But when you're looking at a particular group of people as opposed to people who reside in a particular zip code, do you have any advice in terms of how to identify who are those, somebody talked about the gatekeepers or that sort of thing?
I think the most important thing is that you have to do your research and know your community. And to do that, you have to, you got to come out of your office. I always love these epidemiologists. By the time I get back from the community, they could have had 10 papers written. But I'm out. You got to get out of your office. You got to go to where the people are. You can go to community meetings, just anything related in the community to what you're doing. The research says that health fairs are not, very effective, but yet people say, Sherry, you still go to health fairs. And I said, the reason I go is because that's where the community will be, and that's where they can see me and say, oh, there's Miss Sherry. Sometimes that's how they know me. There's Miss Sherry. And then that's how I start to build that trust, because I'm going and they see me out there at events that they perceive are important to them. And so, no, it's not one person. You may start with one person, but then as people start to see you in the community, you're working in the community, then other people will start to reveal themselves to you as key leaders in the community.
So then they introduce you to Miss Betty.
Right. Miss Betty.
We know who's in charge. Okay, non-roundtable members. Now, folks. Please introduce yourself.
Thank you. My name is Virginia Brown. I'm from the University of Maryland Extension, and I work in the field with Aggies, finance educators, nutritionists, horticulturalists. And one thing I've learned is the set of languages and tools that we use are sometimes transferable, but often we can borrow from other fields to really make our research and evaluation impactful. So I'm just curious, what tools or frameworks are you seeing that we can possibly begin to borrow and use in health literacy research and evaluation in order to tell our story in maybe in a different language, or to begin working with these different people that can benefit us?
As a social scientist, and I'm in the field of communication, we've always borrowed from other different fields, I think. But I think one field that I have come to really respect and I have learned a lot of key lessons from, and that's anthropology. Medical anthropologists, I'm so impressed. Like recently I did a presentation at UT Southwestern in Dallas, and they have a medical anthropologist as part of their research team. And I said, boy, I got to find me a medical anthropologist. So I think we learn a lot, because even though we use these terms like CBPR, really CBPR is not a new phenomenon. You know, anthropologists, they have been doing and using a lot of these strategies, you know, for many, many years. So I would say psychology, medical anthropology, and looking at some of these other different models and frameworks from some of these other disciplines, and combining them with some of the frameworks that we know are tried and true, like the health belief model. I think that the work we're doing now really is basically at a social ecological model, where we have to get really down and look at some of these multi-level aspects of what we're doing, really, as we start to focus on health literacy. And I definitely believe that as it relates to health disparities.
Further questions? We had a second. Yes, Cynthia.
So Cynthia Bauer, Michael was giving me the eye, so I have to get up and say something about the journal that Cindy mentioned, since I am the practice section editor for Health Literacy Research and Practice. So we do talk about the REAIM framework, helping to structure people's report for that section. The reason we included the CDC best practices framework at the end of the paper was we hope people would engage with that as well. We think there's a lot of valuable questions that you can take from that framework. But we do really want to encourage everyone here in the room, people listening through the webinar, to consider writing up your community-based health literacy interventions and submitting them to the best practices section of the journal. That is what that section is for. We have not had a lot of papers come in, and more papers have come into the sort of research side of the house, which Michael shepherds. But we would really love to have papers on many of the things that have been discussed today and probably at previous workshops, because that is what that section of the journal is for.
I thought there was another. Sure, Donnie.
Donnie John with Nova Script Central. One of the things you pointed out earlier was that even if there's bad outcomes, it should be reported. So patients or community members are not going to go to read a peer-reviewed journal. Where can they find out, the reality of stuff? Because, for example, one thing that happened in Minnesota is that the rate of immunizations amongst the Somali population went down and they couldn't figure out, why did the Somali population stop getting immunized? And they discovered that it's because more of the Somali kids were being diagnosed with autism. So there's nobody focusing on addressing the parents' concerns about autism being more easily diagnosed within that population. So now you have all the anti-vacciners that flew down to Minnesota and basically provided bad data and kind of got them to be convinced that if my child gets immunized and I'm a Somalian of ethnic background, then my child will have autism. So you have bad research, but that's all in peer-reviewed journals. The average community member is not going to read that, and especially it's going to be way over their head. So where do you suggest real information to the real public be presented?
I think there may be a few differences. So one is there could be the so-called bad research, where people are claiming something that isn't true, and these movements sort of like the whole Lancet publication. That's we all know about that. This is about. So what I was talking about was if you have an intervention and it did not work, you put your best effort in, you did the evaluation properly. It's just that the intervention was not effective. So publishing those kinds of things just for the evidence base. Definitely, whether it works or doesn't work, we always need some sort of translational products to get it back to the community, to let them know. I mean, they're the ones who are the most affected by the interventions, and I mean, they obviously have a right to know. So I think that's also the dissemination implementation aspect of the work at the guide. We do the reviews, but we also have the D&I, and that's been evolving over the years. So that is definitely very of primary importance, I think, to communicate.
One of the things we do, you're right, they're not going to read the peer-reviewed journals. Many of them probably wouldn't even know where to look for them. One of the things we started doing is we call it a lay health compendium, where all of our research studies we publish in this short booklet, and that we have our community liaisons distributed that to strategic places in the community, like grocery stores, the mom and pop shops, schools, and then we also do a newsletter, and then we also publish little short, I would call vignettes, in the ethnic newspapers, ethnic and minority newspapers, community newspapers, and so that way we're trying to do our best to take it back to them. And again, I said we present a lot of our study findings. We have town hall meetings. We try to do them at least 3 times or twice a year, and we invite community members, have food, invite them to come so we can present the findings back to them.
So in the Ward 8 cab
Yes.
that you talked about, would you be proactive in terms of going to the cab and saying, you might be hearing about this in the future, or there's this story coming out, and here's a reality. So you try to get ahead of it instead of trying to play catch-up, where the messages are already out there, and then you have to do damage control.
Yes. Our Community Advisory Board meets has a standing meeting 3 times a year, but we also have conference calls if there's something coming up where they need us or they we need them. And so the relationship we talked about, it should be a relationship of reciprocity. So many times they'll come to us and they'll say, we really have this issue in this public housing community where the residents, when they turn the water on, it's just dark brown. Well, definitely, I don't do environmental research, but I have an obligation to go back and say who at Georgetown, can help us with this, and pulling together a team of people to help them address that issue. That's part of the reciprocity of the relationship. So it's not just us taking from them information, but when they call us, or just like I got a call, we're trying to put in a DC government small grant. Would you have time to review this? So that's part of that reciprocity relationship. But as far as getting the information to them, you have to use, multiple approaches. And for us, the town hall meetings where we present the findings back to them, we have a listserv that goes out to all the public health communities. Within public housing communities, they have a hierarchy where they have people on site that live in the public housing communities. You can target them, identify them, and they can be a way to disseminate information too.
Thanks, Sherry.
Thank you.
And I want to say thank you to all of our panelists. Please join me in a round of applause. And we will have a 15-minute break, I believe, and reconvene at 3:15.